Thank you very much, Prof, and thank you very much, James, for inviting me to speak. So I think my remit today is not so much to present data, which you've all seen, a lot of the PELA data, the NAILA data, and now from Interstate, but it's really to generate questions and discussions based on what we found in our hospital, how these results are going to impact us, and how it might inform, going forward, a national audit, which I'm sure is imminent. So just a quick background, and again, acknowledgements to James and Catherine for the slides that are from the original PELA talk. But this is just a snapshot of all the studies that have been done on mortality in the last 10, 15 years. And you'll see that most of the mortality ranges are between 11 and 20, and you've heard that prior as well. So this didn't surprise me, but what did surprise me with PELA is that our mortality, even though it is only a 12-week study, it's a prospective study, and we achieved half the mortality that was there. And that, to me, actually raised more questions than anything else. So the primary objective was to look at mortality, but there were secondary objectives, and we've heard all about risk assessments, and I'll talk a bit more about that today, as well as adherence to bundles of care. And just a little reminder of what the bundles of care were that we looked at in PELA. So again, a very brief slide showing the 3 dots, the 4 dots that are PELA, and I'm sure it shows that there's a low volume of main hospitals, but in general, it wasn't as if the average was because we had a high mortality in one hospital and low in the other, but in general, we had a low mortality. So St John of God is probably not the best hospital to talk about, because we're not one of the primary hospitals that have been mentioned before. We're actually a secondary hospital, but we have unique concerns that would affect how the audit results would be presented. We only produced 8% of the number of laparotomies, 0% mortality in this audit period, so it's difficult to draw conclusions from that, and it's also difficult to explain some of the statistics. So this is the standards of care, and you'll see Midland's figures are over there, and we actually didn't do too badly when you looked at the mortality risk in the 5 to 10% and in the greater than 10%. And it wasn't difficult to achieve a consultant anaesthetist surgeon rate of 100% in all our laparotomies, because we had no registrars. So we had no registrars in anaesthetics, and none of our registrars were trainees at the time of the audit, or if they were too junior to carry out any procedures on their own. What does stand out, however, is the early antibiotic rate being extremely poor, as with all the other data. So really, my remit here is to raise some questions and to try and inform how we go forward and what data we collect in the national audit. So there are some controversies in the early antibiotics sphere in sepsis. There's no doubt that giving early antibiotics in severe sepsis does contribute to lower mortality. The question that was raised is, when do you give the early antibiotics? What is the time of onset? So in the NAILA study, that was from the onset of the diagnosis of peritonitis. In this study, it was from the triage and the early warning scores. But that needs to be very clearly defined from a practical point of view, from when you're trying to put something like this into place. What should be used as the trigger? Going forward. There's also difficulties in implementation and recording, and it's no surprise that the recording has been extremely poor during this audit. And so it's therefore very hard to know what was actually implemented when and how much of an effect that has on the data. Also looking at the scoring system that was used. Is it reproducible? Is it valid for WA, for Australia? And can the stratification then be applied to the bundles of care, as was done in PELA? Also, with the mortality being so low, I do wonder whether part of the factor of that was that with WAASM playing such a vital role here, and has been for many years, whether a lot of us are really not doing laparotomies on patients that we might see as futile, and so we've actually reduced the number of those types of laparotomies, which may have contributed to a lower overall mortality as well. And so instead of just looking at mortality, I wonder if we should also be looking at morbidity and length of stay in surrogates like function, return to function, and pre-morbid status. The role of the perioperative physician is definitely now being defined in elective surgery, and I certainly think that it's extremely important that their role is also defined in the future in emergency surgery. And whilst they may not be able to help with the preoperative optimization, certainly in terms of return to function, reducing morbidity, and getting patients back out into the community, I think it will play a very important role. So PELA does focus on mortality. I did say there was a variety of scores that could be used, but the SORT score, the surgical outcome risk tool, was used. Our starting mortality is lower than the UK, and these are some of the points I made earlier. So how do we best measure, discuss and document these going forward? And what is the ideal score? So the SORT score is a 30-day mortality score. It gives you a percentage that says this is your percentage mortality at 30 days. It's very quick, it's very easy. Is it validated and is it reproducible? And I'll come back to that. The PEPOSM, I think most people are very well informed about. It's got good validity, certainly in the studies, but it does include physiological parameters and it can be quite onerous. And I think just pointed out to me today, you also need to do it post-operatively or after you've had your operation, so it's really difficult to generate a PEPOSM pre-operatively. So the NESQIP score has been mentioned before. There's a range of outcomes that are provided from morbidity, length of stay, mortality, and it also gives you the ability to have some surgeon input, but it also can be onerous, although there's an online application for that. So this is the NESQIP and what it can produce. And in fact, as a positive, James, after doing the audit, we've been doing a lot of these, I certainly have on my patients, and I now print these off and give them to the patient and family and put it in the notes with a patient sticker so that we know that these risks have been discussed and identified. And it does give you a predicted length of hospital stay, which is also quite useful. Whether it's valid for Australia is a different question. So I acknowledge one of our surgical registrars who's also doing, Dr. Abe Singh, who's also doing a Master's of Surgery, and she looked at the SORT scores in our hospital from the raw data that we had contributed. And interestingly, you'll see the SORT scores on the left, and then on the right, when they were recalculated using the same parameters. So that was a little concerning that in 12 of the cases, we had some change, and in 5 of them, they were actually significant to change your stratification from either being a very low risk to actually being in greater than 10% risk. And you can see the correlation with the other scores. So what and how should we record it? Should we have 2 unique forms? I believe that sepsis is something that's not just for emergency lab problems. Sepsis, I think, we deal with badly across medicine and surgery because there's a lot of non-operative cases that we treat conservatively, and so maybe we should be dealing with the whole early sepsis treatment as a separate thing and collecting data separately for that. And I thank Dr. Marwan Idris, who provided me with some information about the sepsis evaluation and assessment tool, which has been trialled in Armidale, and that showed that did improve, using that tool did improve compliance with giving early antibiotics and also doing the other things like taking blood cultures early. Should we increase the number of parameters that we've collected in the audit so that we can have a choice of risk prediction scores and also validate that at the same time? If we're going to do a big national audit, then maybe the more parameters we collect, the more we can assess a range of scores and see which ones are actually valid. I've mentioned goals of care discussion. I think that's important. It's helpful if we can do that, obviously, prior to surgery, and so having a risk prediction prior to surgery is important. And I do believe that we should be addressing post-operative morbidity and collecting data, not just using length of stay as an outcome, surrogate outcome, but also looking at complications. We should also be collecting data on where the patient goes. If they manage to get back home, back to their usual activity, whether they end up in a nursing home or hospice, or there's a change from their prior. I'm also going to mention bundles of care. I know that when we looked at patients that were over 10% mortality, we expected them to be transferred out. So I'm in a secondary hospital, I'm not in a tertiary hospital. Well, I am, but I'm speaking with my secondary hospital hat. And what implications does that have? If we don't have the right score with the right validity, it could mean that if we overscore patients, we are then pushed to transfer more patients out or send them to ICU when ICU resources are scarce. So it is worth making sure that we have a score that's valid and reliable. And I'm not sure, in our results, we found that those patients that were risk stratified as 5 to 10% ended up going to ICU more often than those that were stratified greater than 10%. And this is bearing in mind we're using a score that I'm not sure was that useful. So I'm not entirely sure which component of ICU in those patients 5 to 10% is the most useful. Maybe it's just that we need more HDU for certain patients and more regular review leading to early pickup and management of complications rather than the true organ support that's obvious to pick up who needs those. So the plan at Midland now, going forward, having been through this process, is we're very supportive. We think that it's really important that everyone has a risk assessment and a review of their goals of care. We also want to be invested because we're a small hospital and we want to make sure that our patients do get the appropriate care and go to the appropriate place. We're working with ED now to implement an early sepsis tool, and I think we would want to roll this out not just for patients having emergency laparotomies or surgical sepsis, but for all sepsis. We're also working with the anaesthetics to find an optimal risk assessment, and our master student is also going to be doing a study from September for the next 5 months, looking at the ease of use of those 3 scores and any other scores, I think, James, that you may have highlighted. And I think one of the most important things is awareness. So the beauty of having everyone here at the symposium and of having the audit is it's instantly raised a lot of awareness amongst clinicians and allied health staff about the importance of risk assessment and the importance of looking after these patients and how high mortality can be. And I think raising awareness and getting buy-in and discussion as today is extremely important to achieving better outcomes and morbidity. So clearly we have a lower mortality in the study. I'm not sure if that's because it's a short study with a small number of patients, and this is even without good adherence to the bundles of care. So I think that even if we do achieve good outcomes with bundles of care and we get people to follow that, I think it's still important to also look at morbidity and eventual outcomes as well as length of stay. And as I say, simply raising awareness and mandating certain measures may lead to quality improvement regardless of how we implement them. Thank you.